Good morning, everyone. I'm Dr. Hans. Continuing this season, BPD with management part. So, for effective BPD management requires a personalized, multidisciplinary approach focusing mostly on to formulate individual respiratory support strategy to minimize lung injury, select appropriate pharmacological therapy, nutritional strategy, monitoring and manage complications associated with BPD, and plan for long-term follow-up. This graph shows the trends in BPD modality and BPD or modality. The blue line shows the BPD among survivors. The gray line shows the BPD or modality, and the orange line shows the modality. As we can see in this graph, the BPD among survivor is increased, and BPD or modality among the survivors is also increased, while the modality has been decreased from 2014 to 2021. Now coming to the management of BPD. The management of BPD starts from management in the delivery room with fluid and nutrition, some ventilation strategy, and so with some pharmacotherapy. As we have already discussed, the physiological delivery management in the detail. So I will continue with the fluid and nutrition management. To prevent fluid overload, we must use the fluid cautiously, starting from 60 to 80 ml per kg on day 1 with daily increment of 50 to 20 ml per kg. We can maximum reach the fluid management up to 150 ml per kg per day, for which we have to maintain the adequate urine output of 1 ml per kg per hour. Relative fluid restriction, early introduction of enteral fluid, and optimization of parenteral nutrition components should be strongly considered. Coming to the nutrition part, we always try to start or transit enteral nutrition as soon as possible. If it is not possible, we must start parenteral nutrition with adequate calorie and adequate protein. The most important thing in nutrition is exclusive breastfeeding with fresh maternal breastfeed. Was it is seen that it is significantly associated with decrease in BPD and also recommended in the management of early with infant and evolving BPD. In nutrition part, we also consider some vitamins and minerals in the management of BPD, like vitamin A and E, and with minerals, calcium, phosphorus, chloride should be provided. There are some of the recommendations for oxygen therapy. For a thriving child with good growth, no recurrent apnea, no significant respiratory distress, and no pulmonary hypertension, we must consider saturation of 85 to 92%. But we have to target a higher saturation around 90 to 96% in infant with pulmonary hypertension, frequent apnea or cyanotic spells, frequent respiratory exaggeration, poor growth, and feeding difficulties. Now, we have already discussed with early support, respiratory support, and sulfate administration. A child in ventilation, we have to consider or we have to maintain the ventilation strategy to prevent volume trauma, because if the ventilation volume is near or more than total lung capacity or less than functional residual capacity, it both can cause pulmonary edema and release of pro-inflammatory cytokines. Now, there are some rules for ventilation which we have to consider while ventilating a child. Like oxygen can be toxic, hyperventilation may be injurious. As you know, it causes hypocarbia, which is associated with brain injury. Recruitment or decrement causes lung injury. So a perfect ventilation strategy should be used. Lung injury promotes a cycle of inflammation, which is also not good for child. These are some of the ventilation strategy we must consider while treating a newborn, like in the first week and in first to 4 week, we have to maintain a saturation of 85 to 92%, PA2 50 to 70%, PCO2 a bit higher side, like 50 to 55 or 50 to 60 mFHg. In chronic cases, we have to maintain a saturation a bit higher side, like saturation up to 87 to 96%, PaO2 60 to 80%, PCO2 higher side, more than first week and 1 to 4 weeks, like 60 to 65%. In this ventilation strategy, we must consider a permissive hypercapnia. These are some of the ventilation strategy. For less than 1 week, the PEP should be 4 to 5 centimeter. The rate should be up at higher side, like 50 to 60%, and lower tidal volume. And we always try to switch from ventilation to CPAP. In our evolving and chronic BPD, we must consider the rate slower from 20 to 40 with higher tidal volume in chronic BPD, like 5 to 7 ml per kg. And we always consider to taper the child from invasive ventilation to non-invasive ventilation. Now, this is some of the advanced respiratory support which we can consider to minimize lung injury, like techniques like proportional assist ventilation and neurally adjusted ventilatory assist. But it needs a bit larger trial to confirm long-term benefits. Coming to methylxanthine, we have also discussed this in detail in previous slides. So early initiation of caffeine therapy within the first 3 days of life has a significant impact in reducing BPD. It also reduces extubation failure and reduces the pulmonary edema. Coming to steroid. Who should receive the steroid? A baby on ventilator, even after 10 to 14 days, must receive steroid. Usually, it is good to give steroid on second week. Dexamethasone is more preferred over hydrocortisone, and we have to monitor BP and blood sugar while baby on steroid. These are some of the studies we have already discussed in previous slides. As in early period, in Primilog study shows, it is good for surviving without the development of BPD, as increased significantly in preterm infant. But in mid-early period, from 17 to 14 days, use of corticosteroid, it is shown that it has some anti-inflammatory inhibitory effect, but it is not as effective as dexamethasone in preventing the development of BPD. So, in RCT, the administration of dexamethasone in first week of life reduces the frequency of BPD, death, and the need of oxygen support. It also shows that the use of dexamethasone in the early period causes short-term side effect like hypertension, intestinal perforation, GI bleed. Therefore, steroids should be reserved for those with difficulty in weaning preterm babies older than 7 days for extubation. It has been shown from the meta-analysis that dexamethasone administration after the first week of life reduces BPD, BPD or death, and extubation failure. This is the diet regimen which I have already discussed. This diuretic therapy is also one of the important therapy in case of treatment of BPD. Like chronic mild pulmonary edema was included in the initial description of the new BPD phenotype. Both loop diuretics and thiazide diuretics continue to commonly used preterm infant with evolving and established BPD. Baby on ventilator support at 10 to 14 days suspected of pulmonary edema should receive diuretic therapy. We can use furosemide, hydrochlorothiazide, and spironolactone. If there is a response within 24 hours, we can continue the diuretic therapy for longer. Inhaled bronchodilator. it is advised that the use of bronchodilator only in infant with severe BPD with symptoms like asthma-like symptoms, exercise-induced symptoms, or frequent hospital admission. We can use salbutamol with MDI and spacer or nebulization 6 to 8 hourly. Ipratropium can be used alone or in combination with salbutamol. There is limited use of inhaled bronchodilator in acute exacerbation. Now coming to the vitamin A prophylaxis, we can give this prophylaxis to a baby less than 1,000-gram baby or with RDS baby on oxygen or ventilation. The dose we have already discussed as 5,000 international units 3 times per week for 4 weeks. Now coming to the management of established BPD. Ventilator management for infant with severe BPD is especially challenging. There is usually two major phenotypes of severe BPD, which is most predominantly atelectatic or cystic or overdistension. In atelectatic type of phenotype, we have to keep a higher PEEP up to 8 to 12 centimeter of water with tidal volume of 6 to 8 ml per kg. But in overdistension, we have to keep the PEEP in at moderate rate, like 6 to 8 centimeter of water with higher tidal volume of 10 to 12 ml per kg to provide optimal oxygenation and ventilation. In patient with established oxygen-dependent BPD, the use of steroid was successful in weaning supplemental oxygen. Diuretics are continued as in early and evolving phases of BPD. Use of beta agonist with or without anticholinergic may be employed in infant with bronchial hyperresponsiveness. Now coming to the management of some of the BPD phenotype are central airway disease, small airway disease, distal airway disease, and lung vascular disease. For central airway disease, we can manage the child with tracheostomy or a home ventilator. For small airway disease, bronchodilator, steroid, and anti-inflammatory drug can be used. For distal airway disease, bronchodilator and anti-inflammatory drugs can be used. And for lung vascular disease, we can use pulmonary vasodilator, oxygen therapy, and diuretics. Now, coming to the melatonin treatment. It is seen that higher concentration of pulmonary arterial oxygenation, pre-oxidant drugs, concomitant infection, or extrapulmonary inflammation can all promote reactive oxygen species accumulation. For this, Gitlow et al. Researched measure a level of melatonin in 120 newborns diagnosed with RDS and treatment with melatonin to delay the development. But there was no any clear beneficial result with melatonin, but it has some anti-inflammatory effect, which helps in treatment of BPD. These are some of the investigational therapy for BPD, like inhaled nitric oxide, combination of inhaled nitric oxide and surfactant, mesenchymal stem cell therapy, which also shows the promising result in early human study by promoting lung repair, reducing inflammation, and improving lung function. Other investigational therapy are insulin-like growth factor and recombinant hemoclear protein. This is one of the important complications for BPD with mortality rate of 38% to 43% after diagnosis. Some of the other complications for BPD are upper airway obstruction. Abnormalities include laryngotracheobronchomalacia, granuloma, vocal cord paresis, edema, ulceration, and subglottic stenosis. Strata also develop when edema superimposed on underlying stenosis. Other complication like due to diabetic usage, nephrocalcinosis, hyponatremia, hypokalemia, and hypocholelemia can be seen. Osteopenia of prematurity can also be seen with BPD. Some of the CNS dysfunction with ROP and hearing loss also seen. Infection and peritoneal thrive can also be a complication for BPD. Coming to the outpatient management, we can have a multidisciplinary group or consultation. We must send the patient on home oxygen to maintain a saturation by more than 90%. Nutrition support, especially respiratory nutraceuticals, should be given. Routine immunization, including against influenza. RSV prophylaxis is must in case of established BPD, and there should be a developmental follow-up and intervention. Follow-up should be focused mostly on nutrition. This is most important need in BPD. Echo for pulmonary hypertension, oxygen requirement strategy, and pneumococcal and influenza vaccine should be given. So these are some of the take-home messages, like gentle ventilation strategy should be given, targeted oxygen therapy. We can have a permissive hypercapnia, optimize nutrition, neurodevelopment follow-up, and family education and support is most important in case of treatment of BPD. Thank you.